Coming to gastroparesis, gastroparesis means delayed gastric emptying because of abnormal dilatation of the stomach. So how it presents? It presents with nausea, with vomiting, abdominal pain, early satiety. Patient will feel that he is after eating small meals, he is feeling satiety, he is feeling full, and there is a postprandial bloating. The epigastric distension and tenderness can be present, but the typical signs of pyloric obstruction, mechanical pyloric obstruction like suction splash and abdominal rigidity and guarding are absent. And the patients generally, if the patients are on nasogastric tubes, they will tell us that they are having, they will present with increased gastric aspirates, the increased gastric residual volumes, and thus the patients will be malnourished. There will be aspiration of gastric contents, and there will be erosive gastroesophagitis. So common causes of gastroparesis, as I already discussed, are common. The causes of gastroparesis, causes of gastroesophageal reflux disease, causes of ileus, they are mostly common. The patients are having their patients are critically ill. They are having severe diseases like pneumonia, sepsis, ARDS. All these patients will have gastroparesis. They will have gastroesophageal reflux disease. They will have some ileus, also they will have some colonic dilatation. So the common causes of gastroparesis include severe infections, endocrinopathies, diabetes, hypo or hyperparathyroidism, hypothyroidism or hyperparathyroidism, medications that we have already discussed for gastroesophageal reflux disease. Besides that, the narcotics are commonly implicated in gastroparesis. But the vascular disorders, if the patients are having mesenteric ischemia or superior mesenteric artery or median arcuate ligament syndrome, or in post-surgical settings, if the patient has undergone gastroplasty, gastric bypass surgery, these patients are more prone to developing gastroparesis. So what we need to test? We need to check for the electrolytes. If there are some electrolytes which are abnormal, if there are abnormal electrolytes, we should correct those electrolytes. For diagnosis of infection, endocrinopathies, we need to do tests accordingly. And we need to get a plain film of abdomen, either erect or if the patient is not able to sit or the patient cannot be put in a sitting position, we can get a supine film also. And to rule out, if we are not definitely sure that this is gastroparesis and there is no mechanical component to it, we need to do an endoscopy to rule out a mechanical obstruction. So treatment of gastroparesis, what to do? First is to check for the reversible causes, electrolytes, medications, or other causes, and we need to minimize or we need to correct the electrolytes and minimize the medications. For the feeding, we need to use low-fat, small fiber feeds and small volume feeds. Generally, what we do is either we put in the nasojejunostomy tube, NJ tube, or we give a continuous feed through nasogastric tube. So the volume of the bolus feeds are avoided. So what drugs are effective for gastroparesis? Actually, the drugs which we commonly use for treatment of ileus are actually not effective for ileus. These are metoclopramide and erythromycin. So these drugs, metoclopramide and erythromycin, are generally used only for gastroparesis. They have some effect for gastroparesis only. So what are those drugs? How do metoclopramide acts? It actually is a centrally acting antiemetic. And besides that, it also coordinates the antral, duodenal, and pyloric muscle function. So the contraction of antrum, duodenum, and pyloric is coordinated. It results in earlier gastric emptying. But the disadvantage is using metoclopramide intravenously, it has a short half-life, and the levels of metoclopramide peak rapidly and go down rapidly. So thus, if we can use it subcutaneously, it will be better. And how erythromycin works? Actually, erythromycin binds to motilin receptor in the stomach, and this induces high amplitude gastric contractions. Induction of high amplitude gastric contractions results in enhanced gastric emptying. What is the dose? It is 100 to 200 milligram intravenously every 6 hours. Generally, intravenous erythromycin is not available in India. So in some studies, it has been seen that in cases of diabetic gastroparesis, giving oral 125 to 250 milligram of erythromycin 3 to 4 times a day also works. So it is not actually a labeled indication, but off-label you can use oral erythromycin if you don't have IV erythromycin in your hospital. If metoclopramide, erythromycin are not working, you can combine them. Giving a combination of 10 milligram of metoclopramide every 6 hourly and continuous erythromycin infusion 10 mg per hour can be helpful in these cases where either of the agent is not working in isolation. But what is the disadvantage of erythromycin? Since it is an antibiotic, it will lead to antimicrobial resistance. And long-term use of erythromycin will down-regulate motilin receptors and cause tachyphylaxis. So the neuroenteric stimulation, which is used in OPD cases for gastroparesis, is not generally employed in ICU settings. And botulinum toxin has been tried, but it has been found to be ineffective. Coming to ileus. So what is ileus? Ileus is basically abnormality in coordinated propulsive small and large intestinal mobility. So the small and large intestine doesn't move in a coordinated way. So what happens is there is stasis. So again, why this happens? Because of the electrolyte imbalance, because of decrease in vascular perfusion, because of muscle and neurohormonal mediators. And how it presents? The presentation is similar to gastroparesis. How it presents with abdominal distension, nausea, vomiting, constipation, and high GRVs, gastric residual volumes. So it is important to, at this point, to differentiate between ileus and mechanical small bowel obstruction. So there are many clinical features and there are many radiological features from which we can differentiate between between mechanical obstruction and ileus. The most important and simple is to listen for the bowel sounds. Generally, in ileus, the bowel sounds are absent, and in small bowel obstruction, the bowel sounds are high-pitched and active. But you have to remember, in chronic small bowel obstruction, even the bowel sounds can be absent. And the peritoneal signs like guarding and rigidity is generally absent in ileus, but it is present in small bowel obstruction. But you can have patients without guarding and rigidity with mechanical small bowel obstruction. And on radiograph, what will you find in ileus? There will be dilatation of small as well as the large bowel. While in small bowel obstruction, so only the small bowel is dilated, and you can find a luminal cut point. While in ileus, you cannot find a luminal cut point. Air fluid levels are more pronounced and persistent in small bowel obstruction, while in ileus, the air fluid levels cannot be seen. So this is the X-ray. As you can see, the above X-ray represents a ileus. As you can see, the rectal gas shadow is present. And there is a diffuse dilatation of small as well as the large bowel. And the clear-cut air fluid levels are not visible. While below two X-rays, this is erect and this is supine, and this is erect X-ray of small bowel obstruction. You can clearly see there is a dilatation of only small bowel. The large bowel is not dilated. How can you differentiate between large bowel and small bowel? In small bowel obstruction, you can see this venae communities actually crossing throughout the bowel. While in large bowel obstruction, these hostra are actually not traversing the whole lumen of the bowel. And you can clearly see air fluid levels and absence of rectal gas shadow in small bowel obstruction. So what are the common causes? As I told, the causes remain almost similar: electrolyte disorders, inflammation, post-surgery, sepsis, ischemia, MI. All these causes are the common causes of all gastrointestinal dysfunction. How to manage ileus? So initially, we have to resuscitate the patient, correct the electrolytes, mobilize the patient early. So in post-operative ileus, it has been seen early mobilization leads to early resolution of ileus. And secondly, initiate the enteral nutrition as soon as feasible, because early initiation of enteral nutrition has also been found to be effective in management of ileus. And treat the underlying condition. So basically, you have to treat sepsis if the patient is in sepsis. If the patient is having pain, you have to treat pain. So regarding what about nasogastric tube insertion? Do you think nasogastric tube insertion will help in management of ileus? As in most cases of ileus, the first thing that a physician does is to insert a nasogastric tube. But in multiple randomized controlled trials, it has been seen that insertion of nasogastric tube is actually not effective. if there is something which we can get out of nasogastric tube insertion, it is that there are more chances of pneumonia and aspiration of the gastric contents. So we can avoid it if possible to insert nasogastric tube. But if you suspect that there is an increase in intra-abdominal pressure, then you may need to insert nasogastric tube. And as I told, metoclopramide, erythromycin, these have little or no benefit in ileus. And octreotide has been tried, but there is no randomized trial to recommend it as of now. So in cases of the ileus is because of overuse of opioids, what we can do is the traditional approach is to use naloxone, naltrexone, and nalmefene. These are opioid antagonists. What they do is they reverse the effect of opioids. But actually they cross the blood-brain barrier and they reverse the analgesic effect of opioids also. And pain is also a cause of ileus. So what happens? So what to do? There are some newer peripherally acting mu opioid antagonists like methyl naltrexone and naloxegol. So these agents, they don't cross the blood-brain barrier and they are efficacious in treating opioid-induced constipation without significantly decreasing the analgesic effect of opioids. So methyl naltrexone in the dose of 0.3 milligram IV every 6 hourly can be used. In cases of post-operative ileus, another selective mu opioid antagonist, Alvimopan, has been tried and it has been found effective. In one study, it has been shown to decrease the time to discharge, decrease the time to initiation of bowel movements, and it has even been found to be efficacious in treating opioid-induced constipation. But this Alvimopan has some cardiovascular side effects. That's why it has not become very popular.